has not received its due. We are still stuck in old term practices and we are still writing combinations of wellness patterns and all that things. So we'll try to debunk some myths about this chlorthalidone drug and we'll try to see how this can be result into in practice. Chlorthalidone for hypertension control and beyond. So you know that hypertension leads to heart failure progressively. So heart failure still presents a major health problem despite significant things we know about heart failure. And hypertension is a major risk factor. We know all that many of our patients who come to us, they usually have hypertension long, and it is present around in 75% of the patients with hypertension. And with chronic heart failure, and it is the most important cause of heart failure with preserved ejection fraction. There are three terms in heart failure with reduced EF, heart failure with preserved EF, and heart failure with mid-range EF. So this says 75% of the patients with preserved EF, it is the most important cause, and also in obese patients. Okay. How from hypertension we land up in to heart failure. So it is a complex interplay of all the factors we have. Hypertension leads to left ventricular hypertrophy. It further leads to LV dilatation, remodeling, LV dysfunction, and further all these things lead on to heart failure in the form of less tissue perfusion, increased hospitalizations, and death. And if there are coronary risk factors in the form of diabetes and other things, then LV damage is quite early and it all leads to LV dysfunction. Okay. So this is a very famous study that you must be knowing. It has been in news since 2015. The SPRINT trial, largest trial of hypertension, it was published in NAGM, and they found even with intensive treatment and standard treatment, heart failure was present in all the groups. In intensive treatment, the heart failure was quite less as compared to standard treatment. Means heart failure leads to complication for heart failure. Okay. So, what are the antihypertensive classes for the prevention of heart failure? What should we do when we see that hypertension is the most important cause? Diuretic-based therapy represents the best treatment, and we know it is more efficient than ACE inhibitors, ARBs, and calcium channel blockers were among the least effective first-line agents in the prevention of hypertension, together with beta blockers and angiotensin blockers. This study came in 2011. So when you suspect that patient is going into heart failure or will land up in heart failure, we have to start a patient on a diuretic-based therapy. So this is again a very good slide where thiazide use and decreased risk of heart failure in non-diabetic patients receiving intensive blood pressure treatment. As we see in this chart, the patients who were on thiazides, their primary outcomes and heart failure were much significantly lower. It was 81% lower than patients taking thiazides were not taking thiazides. But out of those, we have thiazide drugs and thiazide-like drugs. What we are talking about is thiazide-like drug that we'll discuss in coming slides. Okay. And in all the cases, association with thiazide use and primary outcomes, thiazide use was better in patients in high systolic blood pressure, in patients having albuminuria, in patients having CKD, in patients having CVD, in obesity. All the patient thiazide scores better than the other drugs. Okay. So if we compare diuretics with other classes, with beta blockers, with ACE inhibitors, with calcium channel blockers, in all those risks, if we specifically see CHF, diuretics always favor. If we compare with ACE inhibitors, with calcium channel blockers, here also we can see P value is quite significant, and of course with beta blockers, P value is quite significant. So, in patients, we are suspecting that they will go into CHF or already in CHF, we should add thiazide-like diuretics. Okay. There is 43% reduction in heart failure with thiazide-like diuretics, while there is no significant reduction with thiazide-like. Thiazide type drug is hydrochlorothiazide. Thiazide-like diuretics are chlorthalidone. You should know the difference. If we are talking about thiazide type, it is hydrochlorothiazide. But if we are talking about heart failure, it is thiazide-like is chlorthalidone. Okay. This is a very good study that came in a very reputed journal of American College of Cardiology. Efficacy of low-dose chlorthalidone and hydrochlorothiazide as assessed by 24-hour ambulatory BP monitoring. And here we can see that low dose chlorthalidone with 6.25. And there is one more thing I want to stress, that what I do in my practice, 6.25 and 12.25 doses hardly make a difference. Even if you want to control blood pressure, it can be controlled with a drug of 6.25 also. It is not necessary कि मैंने 12.5 की गोली डालनी है. 6.25 is sufficient for us. So treatment with low dose chlorthalidone significantly reduce 24-hour ambulatory blood pressure as well as nighttime blood pressure due to its short duration fraction. No significant 24-hour EBP reduction was seen with hydrochlorothalidone, since it has a short duration fraction. Okay, and of course, which mainly converted sustained hypertension into masked hypertension. So chlorthalidone scores much better over hydrochlorothalidone. SHEF study means systolic hypertension in elderly patients. So chlorthalidone treatment in subjects who had diabetes, they had lower long-term severe mortality, they had lower total mortality, and who had diabetes, there were no significant increase in cardiovascular events. So in elderly, we usually prefer giving chlorthalidone along with telmisartan. So again, same slide, the heart failure outcomes from the SHEF studies showed 50% reduction in heart failure with CTD if we compare it with placebo. Okay. This we have discussed. Now, okay. What are the long-term effects of diuretic-based therapy on fatal outcomes in subjects who had systolic hypertension with or without diabetes? There is one caveat that we should know. Patients who are on chlorthalidone, they tend to develop diabetes as a side effect. But that side effect is not much significant. आपको लगेगा कि मैंने क्लॉरथैलिडोन अगर शुरू कर दूंगा 3 साल बाद इसको शुगर हो जाएगी. ठीक है, शुगर होगी, पर उसका इतने आउटकम्स नहीं होंगे जितने अगर हम दवाई स्टार्ट नहीं करेंगे. Diabetes that developed during chlorthalidone therapy did not have a statistically significant impact on CVT mortality or all-cause mortality in contrast to DM that developed while assigned to placebo. So it is, we can say कि 3 साल बाद मरीज को थोड़ा सा शुगर बढ़ेगा, पर उसका उतना कोई साइड इफेक्ट नहीं है. पर उसके जो बेनिफिट्स हैं CTD के, वो शायद बाकी ड्रग से नहीं मिलेंगे. So in mild hypertension, it significantly decreases the LV mass if we compare it with ACE inhibitors, right? So these are the all slides we have taken from different trials. LHART study, again, the risk factors of heart events were higher with amlodipine, and it was higher with tisnopil if we compare it with chlorthalidone. Okay. So this we skipped. This is again another trial which showed hospitalized for congestive heart failure was much less in the this group in the diuretics group. So now coming on to JAK heart failure, this is what if patient is already diabetic. Now there is a dilemma कि patient को diabetes भी है, ऊपर से chlorthalidone में आगे क्या होगा? Okay, diabetic hypertension and diastolic dysfunction, use of calcium channel blockers. It was found out that in diabetic hypertensives with a diastolic dysfunction, thiazide-like diuretic should be preferred ahead of CCBs for blood pressure control. You should not blindly come, if a patient is coming to us, we normally start the patient with a combination of telmisartan or amlodipine. You should think for some time and you should think what drug will benefit the patient, whether a calcium channel blocker or a diuretic. So again, it helps reduce heart PEF by 31% if we compare with amlodipine, with lisinopril, and it also reduces HFrEF with 26% with amlodipine. PEF means preserved EF, R means reduced EF, and that's fine. Again, benefits I've already discussed. So what I was talking is the LHART report in diabetes. So there is only marginal less than 3 milligram per deciliter increase in fasting plasma glucose over 4 years. Even if we start patient on chlorthalidone, hardly 3 milligram per deciliter will hardly make a difference. So I think this will not bother us, and we should start patients writing on chlorthalidone. Okay. This we have discussed. Now, what are the recommendations? What we as cardiologists follow, and what are the latest guidelines say? Clinical recommendations on chlorthalidone. In kidney disease trial, there is little evidence being available on the supportive use of diuretics to treat patients in hypertension with advanced chronic kidney disease. But if we start giving chlorthalidone, there is minus 10.5 millimeter decrease in blood pressure if we compare it with placebo, change in 24-hour SBP, change in 24-hour SBP from baseline, it is 54% lower with chlorthalidone group, and it is 21% lower in the chlorthalidone if we see it over a period of baseline in 3 different trials. Okay, so what we conclude is patient with advanced kidney disease and poorly controlled hypertension, chlorthalidone therapy improved blood pressure at 3 months as compared to drugs with placebo. So it is a very useful drug in CKD patients also, and we should prefer giving these drugs as compared to conventional drugs we use, for example, torsemide. Okay, this we have seen that chlorthalidone is significantly reducing the blood pressure. This we can skip. The recent guidelines from Association of Physicians of India, what they say, we know already in older patients we usually start with C or D. We know A or B is angiotensin ACE inhibitors or ARBs, while in older patient it is calcium channel blocker and a diuretic. And nowadays it is not a simple loop diuretic, it is a thiazide type drugs like chlorthalidone. Okay, so this is the phenomena we have been taught. Then if it is not controlled, we either add A plus B, C or D. Step 3, we keep on adding drugs according to the patient response. But you have to remember, in older patients we usually start with C or D. Okay, especially D. So everybody, even European Society of Cardiology, they also prefer giving chlorthalidone. Again, Diabetic Association of India, they are also thiazide-like diuretics like chlorthalidone are superior in blood pressure reduction as compared to in resistant hypertension. So this we can skip. Again, WHO guidelines, they have also from 21 they have included first-line drug as thiazide type agents. Okay, so again, European Society of Hypertension, they also recommend this same thing. So we'll just skip it and we'll just come to the. This is a cardiology update. What VCSI stands for Cardiology Society of India, and they had a good chapter on this, the choice of diuretic in treatment of hypertension. And what they suggested was chlorthalidone has emerged as a superior diuretic given its versatile nature, long duration of action, especially when used in combination with potassium sparing diuretics. Owing to these advantages and unique benefits, I am reading quote by quote. In Indian context, chlorthalidone now seems to be the answer to the long-standing debate on the diuretic of choice in hypertension management. Okay, so this is from 2023. It is a recent ones. So coming on to conclusion, this is the last slide for today. This is a summary. It is superior than other drugs, and they have hypertension and diabetes have negative synergistic effects. So CTD has shown to be superior over HFpEF. It reduces the risk of stroke and offers life extension. More beneficial effects in preventing heart failure in diabetics. It is recommended by various guidelines, and can be used in advanced CKD patients, and it is being given in all the books, all the guidelines, and of course in elderly patients it is the drug of choice of hypertension. So I have kept it very brief just to keep the topic limited to CKD. And if any questions regarding this, you can always ask me. I'm here. So I think we'll finish it off. I would love to take questions. So. Any questions? I did it very fast, but since I was already very late, so I would like to take any questions if you have.
Any question?